Legionnaire's disease. Legionnaire's disease is important to monitor because it is common in residential settings. It is caused by the waterborne bacteria Legionella, can affect humans through sources of water in the home, and is most likely to attack those who are immunocompromised, above 50 years old, are current or former smokers, or have pre-existing medical conditions such as diabetes, kidney failure, or liver failure. The number of cases of Legionnaire's disease has increased 4.5-fold between the years of 2000 and 2018. Legionnaire's disease is a severe form of pneumonia that originates from the waterborne bacteria Legionella. Legionella is typically found in freshwater sources, but can become a health concern when it spreads through man-made building water sources, such as showerheads, sink faucets, cooling towers, hot tubs, decorative fountains, and large plumbing systems. After Legionella grows and multiplies in a building water system, water containing the bacteria must be spread in droplets that are small enough to be inhaled by humans. When someone ingests water droplets containing Legionella, they can get Legionnaire's disease or Pontiac fever. Humans can also become infected with Legionnaire's disease by drinking water that is contaminated with Legionella, although that is very rare. In order for this to happen, the bacteria must enter the lungs. Legionnaire's disease is similar to other forms of pneumonia and includes symptoms such as cough, shortness of breath, fever, muscle aches, and headaches. However, it can also be associated with other symptoms such as diarrhea, nausea, and confusion. Symptoms of Legionnaire's disease usually occur 2 to 10 days after exposure to the bacteria. Although less common, Legionella can also result in Pontiac fever, which differs from Legionnaire's disease because it is not a form of pneumonia and it is much milder. Symptoms of Pontiac fever include a fever and muscle aches. Symptoms begin a few hours to 3 days after the individual becomes exposed to the bacteria and usually lasts less than a week. The Wisconsin Health Department reported a case of Legionnaire's disease recently. The patient was between the ages of 70 to 79 years old, was immunocompromised, and a non-smoker. The patient was admitted to the local hospital after being evaluated by emergency personnel for a rash and a fever. It was assumed to be a reaction to oral antibiotics that had recently been prescribed to the patient. Upon being admitted, a family member of the patient reported a change in mental status of the patient, and after being admitted, the fever and mental status of the patient worsened. 5 days after being admitted, the cough worsened and became productive with a dark brown sputum. On day 6, tests for Legionella, specifically L. pneumophila, were ordered through a urinary test. The results came back negative. The urinary test tested for serogroup 1 of the disease, which is responsible for most infections. However, it was later discovered that the patient had serogroup 3 of L. pneumophila. On day 10, the patient died due to cardiopulmonary arrest. Then, tests for Legionella began to be conducted in the hospital and the patient's home to find the source of the bacteria. All samples taken in the hospital came back negative. The patient's home was tested next, and the bacteria L. pneumophila was found in the patient's water supply. The house was flushed according to guidelines and recommendations, but the water still tested positive. The bacteria responsible for the patient's case of Legionnaire's disease was determined to be L. pneumophila serogroup 3, sequence type 93, and was determined that the patient was infected with the bacteria in their own home. This shows a timeline of the patient with the disease. It shows when the patient started showing symptoms, day 0, which was when the patient was admitted into the hospital, when samples were taken, and results when they were received. The hospital that the patient was admitted to requires that certain actions be taken if a patient tests positive for Legionella, mostly to determine the source of the pathogen so that others do not become infected. Samples were first taken in the hospital. Different sources of fresh water within the hospital were either swabbed or collected in a bulk sample of 250 milliliters, or both, to determine if the water source had the bacteria. All samples from the hospital tested back negative. To collect samples in the patient's home, the same technique was applied. Different sources of water around the home were swabbed or collected in bulk samples of 250 or 550 milliliters to send to labs to test for the pathogen. This displays the results from the tests done within the hospital. As you can see, water sources were tested from various parts of the hospital, and the majority of samples were taken 17 days after the patient was admitted, with there being follow-up samples in the patient's room sink faucet and shower 40 days after the patient was admitted. The majority of the tests were tested in the hospital laboratory, and all test results came back negative. These are the results from the patient's home. There were 2 samples done, an initial one on day 26 and another follow-up sample on day 62 after the home water system was flushed. The samples from the home were primarily tested at the Wisconsin State Laboratory of Hygiene. On day 26, the bacteria was tested positive in the showers of bathrooms 1 and 2. The shower in bathroom 1 had a colony-forming unit of 2.54, and the shower in bathroom 2 had a colony-forming unit of 0.36. When the second round of sampling was done, the bacteria was present in the sink of bathroom 2 and in both sink sprayers in the kitchen. However, the colony-forming units are lower, indicating there are less of the bacteria present after the flushing. This is a brief summary of the test results that were discussed on the previous slides. On day 52, the health department followed the advice from a 2010 home guidance manual to remove Legionella from the home's water supply. A plumber drained, cleaned with chlorine, and superheated to 148 degrees Fahrenheit the home's water heater and then flushed the fixtures over a 3-day period, and shower heads were soaked in vinegar to remove the hard water scale. As previously noted, when samples were taken again on day 62, Legionella was still present in the home's water supply. After the second round of samples were taken, no further samples were taken. The home guidance manual was shared with the other resident in the home who was not immunocompromised and did not become ill. Practices to prevent Legionella growth were also discussed with the other resident in the household, such as adhering to recommended water heater settings and maintenance schedules, and flushing water fixtures after lack of use. The other resident was encouraged to seek medical attention if they did become ill. In order to fully understand the burden of disease of Legionnaire's disease, there has to be increased monitoring. In Wisconsin, the cases of Legionnaire's disease have increased by more than 400% from 2010 to 2018, which is consistent with the overall trend in the United States. Approximately 9% of cases of Legionnaire's disease in the United States are fatal. Improved testing and treatment of water systems, especially in residential areas where this bacteria is prevalent, is critical to reduce the number of cases. There could also be more education efforts in communities where the bacteria may be more present to help them understand the symptoms and how to prevent and protect their home water supplies from becoming infected with Legionella. This case also highlights the value of obtaining lower respiratory tract specimen for both patient treatment and public health investigations. In the case of the patient in this report, the lower respiratory specimen may have helped to diagnose the disease sooner. Because timely antibiotic treatment can affect patient survival, the CDC recommends concurrent ordering of Legionella antigen test and culture of lower respiratory tract secretions for patients with suspected Legionnaire's disease. Also, the published guidance for the prevention of Legionella growth and spread is limited to complex building water systems through water management programs and, when indicated, immediate control measures such as point-of-use filters. This can be improved by more published material and guidance for at-home water systems that are not as complex, as well as other methods to control the bacteria that are not necessarily immediate, such as prevention measures.